And in 1999, Congress asked the Institute of Medicine to look into the issue of racial and ethnic disparities in healthcare. And the question was, we know that public health issues play a large role in disparities and the fact that minorities tend to do have poorer outcomes for diabetes and heart disease and other conditions. We know that access to care plays a large role, and for example, we know that there's 46 million uninsured Americans, about a quarter of them are Latinos, so you know that they're going to be at a disadvantage if they have to depend on emergency rooms or underfunded community health centers to get their care, so we know that plays a role. But what Congress said is, we're seeing a lot of research that shows that if two people present to the emergency room with chest pain, and they have the same level of insurance, same socioeconomic status, same education level, that one might get cardiac catheterization and bypass surgery and really get excellent care, and the other patient might get discharged with just some medications. Or if two patients present to the emergency room with a fracture of their arm or of their leg, some patients, in this case African Americans and Latinos, tend to get less pain medication for the same exact fracture than do their white counterparts. And they said, are these differences real? And I had the honor of sitting on a committee that studied this issue at the Institute of Medicine for 2 years. And we said, yes, we see differences. We see disparities, differences in the care that people receive based on their race, ethnicity, even when they have the same insurance and socioeconomic status. And I think this is a big revelation to many, and I don't think it was a revelation to many of us in this room who live and experience these disparities every day. And of course, language barriers play a very major role. We had a lot of recommendations as to how the healthcare system should be addressing these issues. And one of them was doing more to facilitate interpreter services, both from the standpoint of funding and certification and support. That was one of our major recommendations. So we really realized and understood that language barriers play a very effective role. It's not rocket science. If I can't communicate with my patient, if I can't communicate and take a history, then all these years of learning all this information is worth nothing. And I think we all understand that. And so we said that interpreter services were very important, and clearly we see that patients who are suffering from disparities also tend to have, in many cases, limited English proficiency and have difficulty navigating the system. Now, here's the new language I want to share with you, because disparities, I think, is the obvious hook for us as we try to push for interpreter services and to push this agenda forward. And I think it's the easy and obvious one. But in some ways, I think it still puts the issue of language barriers among kind of those groups over there, right? Those minority populations, those immigrants, it's still kind of an issue not about us for many people, it's about those over there. And even as it relates to the disparities issue, I'd say many people in healthcare leadership, and we've seen data on this, say that, I may believe that disparities exist, but they definitely don't happen in my hospital. I know they happen over there at that hospital, or I know they happen at that place. It's kind of very powerful not me phenomena, right? And I think that's real. But I want to shift gears and say that another very influential Institute of Medicine report came out a couple of years back, and it talked about quality of healthcare, and our nation should really be focused on quality of healthcare. And it said that if we are to achieve quality in healthcare, our healthcare should be safe and free from medical errors. It should be effective based on the best science that we have. It should be patient-centered and responsive to patients' needs, values, beliefs. It should be timely. Patients shouldn't have to wait unnecessarily long waits for procedures or tests and the like. It should be efficient so that we shouldn't be wasting any resources, and it should be equitable. We shouldn't see differences in outcomes based on race, ethnicity, language, gender, okay? So what's important, the important thing to know about this report is that this has reshaped the American landscape around healthcare and the way healthcare organizations are thinking about their services, right? So at my hospital, at Mass General, we're looking at every one of these 6 areas and really focusing on how to make sure our organization is hitting on all 6 of these cylinders. They're called the 6 pillars of the IOM report, Crossing the Quality Chasm. So why am I telling you this? How does language fit into this? Well, this is what I'd call the mainstream language that our leaders are speaking. But let's take a look at what I just told you, these 6 pillars, and what the evidence tells us about language barriers and its relation to these areas, right? So, safety. Healthcare systems should be safe and free from medical errors, including avoiding misdiagnosis, preventing unnecessary risk, and achieving informed consent, right? I think you all know it's tough to get informed consent, near impossible if you have a patient with a language barrier. But you know, just a few years back, there's a wonderful paper that came out, actually just last year, from the Joint Commission, in fact, that looked at medical errors in hospitals. And they looked at a set of hospitals, and they found that patients with limited English proficiency were more likely to have medical errors, and the medical errors were more likely to have greater clinical consequences than with their English-speaking white counterparts. So again, if you're a healthcare organization and you're worried about safety, it's critical that you attend to the issues of language, and we have evidence here that supports that, again, proving the obvious, that if you have a language barrier, you're more at risk of a medical error, and it may have very significant clinical consequences. Effective, right? We should use evidence-based guidelines for all patients, you know, consider their preferences and values, and we see research that shows that, for example, limited English proficient patients, in this case Spanish-speaking patients, are discharged from the emergency room less likely to understand their diagnosis, medications, instructions, and plans for follow-up care. When we talk about patient-centered and being able to deliver care that's respectful and responsive to individual patients' health beliefs, needs, and values, again, research that shows us that Spanish-speaking patients are more likely to report problems with their care and to be less satisfied with the patient-provider relationship. Around timeliness, avoiding delays due to systemic barriers or provider-patient misunderstanding, patients with limited English proficiency, in a recent study that just came out, have longer waits in the emergency room. And what does that do? Backing up the entire system for hospitals. In some cases in Boston, we have hospital diversion rates being very high. And so can that be a hook for us as we think about this issue? Efficiency, which I think is really, really important. Avoiding unnecessary costs due to poor communication, missed health promotion opportunities. Two very important studies that I think you should be aware of. Number one, a study that was done just a few years ago that looked at patients who presented to the hospital with the same condition. They looked at discharge diagnosis, right? And they looked at these patients also by language, by English proficiency, right? And they found that if two people are admitted and have the same diagnosis, individuals with limited English proficiency more often than not have longer lengths of stay than their English-speaking counterparts. So they're in the hospital longer. And I think, you know, for my hospital and for many hospitals, length of stay really matters, right? You know, length of stay is like the hook. You want to get your admissions up, length of stay down, and that's how you get your numbers right. So, I mean, I think this is important for us as well, in addition to the fact that patients may be put at additional risk by being in the hospital an extra day or two. The other one that I like to talk about a lot, several studies in this area. Classic study, a patient presents to the emergency room, no interpreter. Patient says, bueno, tengo dolor de cabeza, and you know, you can't really communicate. It could be sinusitis, or it could be a subarachnoid hemorrhage, right? And that emergency room doctor is left with a choice. Now, you know, I have not a lot of time. I can't quite figure out if this is just, you know, something simple or not. And so off that patient goes to an $800 CT scan, where, you know, an interpreter as a technology could have really, you know, saved costs and gotten a better outcome if in fact it was something like sinusitis. So that is a real example of really poor efficiency when we're not attentive to language barriers. And finally, I think the equity piece is again the one that falls nicely for us. We know that not being attentive to these issues leads to these differences in quality of care. So let me just end by saying that what I've tried to do is share with you the battles that we're trying to fight in the presidential suite of hospitals and health plans, right, in the leadership. And we're trying to say, you know, this isn't just about outlaying cost and all these things. This has real significant implications for the quality of care that we're able to deliver. And if we're not attentive to these issues, we are not hitting on our mission. And I think that's the message we need to be conveying to our leadership. Now, I strongly believe that we need to let leadership know that addressing language barriers won't just help us address disparities, it's going to help us improve quality of care for all patients we see. That interpreter services aren't a luxury, but a necessity. And finally, that medical interpretation is a science with solid standards that need to be disseminated wisely. And I think that's your responsibility, and that's a responsibility of all of us collectively here, is making sure that we, when asked, well, what are the standards, or what should we be doing, or what is the expertise we need, we're able to answer with a resounding, you know, yes, we can, here are the details, and we are ready to help you in this regard. So with that, I thank you so much. I look forward to the comments of the speakers who follow me, and I wish you all the best of luck. Thank you.